Thank you, Ingrid. So my assigned topic was MIS in the era of robotic surgery. So when I go back historically, way back to the 1980s, uh, that's when my journey into MIS started. At that time, of course, there was no laparoscopy or robotics. At that time, we started with the percutaneous approach to the kidney. So that was the first foray into uh, MIS in urology. So, why do we push the MIS over the past literally 4 decades? Minimize the scars, minimize the agony, the time to recovery, and things that happen after that. So, this is my residency. So, when I was doing my residency between 1977 and 1982 at Tulane, this was standard. Initially, we didn't have the clips, then we got the clips. We had to suture the skin with silk or things like that. But you can see that it does leave evidence, the scars, the hernias, the pain, the infection, you name it. So, but we had no choice because at that time all we had was the knife, chromic catgut, silk. So that was it. In any part of the world, you got to put up with what is available as a standard of care. So as we look at surgical progress, which is important, what are we trying to do? Whether it's today, yesterday, or 3 decades ago, decrease the pain. The patient needs to get back to work, get back to normal activities, decrease complications, improve outcomes. So this has not changed over the past 4 or 5 decades. It's just that now we have better tools uh, for management of our urologic problems. Like I said, 1981, 82 is when this was introduced. And this was the kidney surgery that I used to do. So nephrolithotomy, ureterolithotomy, anything to do with the stones, we had a flank incision. And that's a painful incision because you're transecting the muscle fibers, the nerve fibers, uh, the, the, the hernias, or at least the weakness of the muscles was very evident, no choice. But then we had to put the patient on stretch, go through the muscle layers, so on and so forth. The residents today have no idea what an Alexander or certain instruments that we used routinely. So that's gone to the museum at the AUA, but this is what we had to do, no choice. So that's when PCNL, and then we can leave that to the giants in history who introduced us to this, so that now we're able to go through half an inch incision and then go ahead and remove the kidney stones. Then, of course, we had a plethora of ultrasonic lithotripters and so on and so forth that helped us in this process. Not enough of flexible in endoscopy then, but now that's also much better. So that opened up a whole new arena of not making incisions. And then, of course, my first ureteroscopy was in 1984. Uh, uh, the rigid was all we had. It was 11.5 French. It was an easy. We had to dilate the urethral orifices, but we could get it done. We had to use the devices. There was no real lasers at that time, but we had to use the electrohydraulic lithotripsy to break up stones, use the baskets available. There were no nitinol baskets. We just had the baskets that were actually more invasive. So for the young urologists here, what you are now seeing is a quantum leap of convenience for your practice and for your outcomes. And of course, now we have all the flexible scopes that we can go through, not only for the urethral, but also now big time for big stones in the kidney. I always say when you're doing a big stone larger than 2 centimeters, which a lot more people are suggesting, to go retrograde, then be careful to protect the ureter because that can be a complication. In 1985, we introduced ESWL. That was when the FDA approved it in the US, and that changed management of kidney stones as well. This was the original HM3 Dornier, which then became the tabletop models. And so basically, in about 3 years, between 82 and 85, we went from a major incisions to no incisions. So that is what was the first revolution, not evolution, but revolution in management of kidney stones. Then, of course, this led to another set of MIS procedures such as cryo. For those who are with that, this was around 1990, 91, 92, where we could now look at focal therapy using the grid system. Not too bad, but then we had to have a lot more urethral warming and stuff like that. Brachytherapy, where you're putting seeds into the prostate using a certain formula based on the weight of the prostate and the number of seeds, etc. So all this was part of the MIS in the 1980s. 1991, that's when I did my first urologic laparoscopy. And at that time, people said, "What the hell are you doing, Raju? Are you looking for an indication for a procedure?" So that was 1991. And of course, then the rest is history. This is, you can see how in 1990 was the first laparoscopic nephrectomy that was done in St. Louis. With laparoscopy, I was able to introduce the radical perineal prostatectomy as a one-stage, no dissection, turn the patient over and get it done, radical perineal prostatectomy done. And then, of course, with the laparoscopy, we were then able to do prostates, cystectomies, nephrectomies, partials, and so forth. Certainly, for those who have not done laparoscopy and have jumped into robotics, you will notice that pure laparoscopy does take a toll on your back as you got to stretch out to do your vesicourethral anastomosis and stuff like that. But now things are much easier. The robotic surgery started way back in '85 for the neurosurgical biopsies and the Probot, which was in London for TURP, and then of course the cholecystectomies in '87. In 1998, I was able to use the ESOP. So it's ESOP, turn right, turn left, and the camera moves, and you were able to use the robotic laparoscopic platform. Prior to Intuitive Surgical purchased the computer motion company and shut it down so that they would have no competition. So that all we had was the Da Vinci system since the year 2000. This was the Zeus platform that I just talked about. And then, of course, there's been a whole range of robotic platforms available. And of course, today, the Intuitive Surgical has a lot of competition from around the world, including the MedBot, which is made in China. Literally looks like, when I used it recently, it was like almost like I'm sitting on the Da Vinci platform. So now we have the single port, multiple port, the Da Vinci 5. This morning when I was up on TV in my room upstairs, there was a feature on the Da Vinci 5. Like, it's a big deal, but we've been doing robotics now on the Da Vinci for the past 24 years. But this will keep improving and improve access to the robot. So when we started in 2000, 2001, 2002, there was really no guidebook because those who were doing laparoscopy could get into the robotics. So there was no roadmap. We just had to say the anatomy is there. Now I can navigate it without my assistant moving the camera for the pure laparoscopic. Even though there were some clips you could attach onto your surgical table. So we had to go to seminars, learn, etc. At the AUA meetings from 2002 onwards, a lot of traffic went to the Intuitive Surgical. So it was a literally something that took off by itself, was not part of the curriculum until after 2005, 2006 for the RRC and ACGME. But what set aside the robotic platform was there was robust data collection and presentation. So we were really looking at incontinence, impotency more diligently rather than retrospectively and stuff like that. There were certainly superior outcomes in several areas, and this technique caught on. Why in the U.S.? Because as surgeons, we are present confidence, but we are inwardly a bit insecure. How come at the other part of town they're doing robotics and I'm here, I don't have it? That insecurity fuels the rush to go make sure it's being done. So that really what happened in the US. Uh, the uh, the future of MIUS is here, and pushing of the envelope will continue. In one of my lectures at this meeting, I look carefully at the role of laparoscopy. So when I'm up here, I'm not saying you have to have a robot. Absolutely not. Surgical treatment is based on the community. If you are in Zambia, is different from Panama, is different from New Orleans. So you have to stick with the standards of the community, and the patient need to know that in Zambia there is one robot available, that they are welcome to go there, but the patients cannot afford to travel to go, so they will get the open incision. That is the standard of the community. So there is no way anybody can force things because there is called personnel available, training needed, finances to be looked at. So there are so many multiple things in uh, this world of ours which is not equally distributed. So there's going to be areas that have no access. Close to 70% of the world has no access to the robot. What do you do? So you just do what the best you can. If you have uh, laparoscopy, stick with laparoscopy as the harbinger of minimally invasive care that you can provide for your patients. So this is important. The pushing of the envelope will continue. So now you can see the cost has gone down a little bit, but not way down with these multiple uh, platforms available around the world. Uh, in China, there are ones in England, Korea, India, etc. They are building their own robots. A different platform. You can have 3 arms, 4 arms, depending on how much you want to use it. So, if you're looking at it now, there is competition. There is something that you need to see what is best for your marketplace and your patients, and then it also depends where you're practicing. Is it hospital based, where the hospital pays your salary, because then they can afford to get equipment? Are you in a large group, 8, 10, 12, 15? Then two or three of you will be specializing in robotics. Are you in academic, where you got to train the next generation of urologists to make sure that the practice continues? Are you in a 1, 2, 3 man group where it might be difficult to go and learn and spend the time? Cost is always a constraint. What do you do if the less expensive robots are not available? So you need to make sure that the less privileged parts of the world are also taken into account. That's where meetings like this is important, because it brings people from around the world to think globally. Certainly, this is more for the men's health, but this can be for both in terms of the partial nephrectomy or the hysterectomy, etc. So we need to disseminate the philosophies and the technology. How do you teach our next generation? How do you proctor them? Are they going to be up to snuff in terms of working on the robot safely? And that can empower urologists around the world. The robotics is going to be loosely used for many things. This is the Monarch robotic system that was developed for the lung so that it would actually, just like a video game, it can be put into the bronchus and it will go into the different bronchioles and you can actually do a biopsy. So now this is being transformed to see if we can use this in the ureter and in the kidney for stones, biopsies, etc. So this is going to happen, including management of the low grade isolated tumors using the laser technology. Certainly, using the flexible scope, going and taking care of stones is well known to you and being used almost everywhere where the technology is available. So what we have seen is that with the nephroscope, the ureteroscope, the lasers, the laparoscope, the advanced imaging and diagnostic, and all the robotic platforms, we are really keeping up with getting minimally invasive, decreasing the morbidity, increasing the productivity, and getting people back to life and normal activities as soon as possible. Thank you very much. On time.